Dr. Patel, you're a orthopedic surgeon that specializes in shoulder surgery. I want to know what your clinical take is.
My clinical take as a shoulder specialist right now, working in the community, is that there are far too many people undergoing unnecessary rotator cuff related repairs or rotator cuff related surgery.
Why do you feel like this is happening?
The reason it's happening, and you can attest to this as someone who does pain management, is that pain is sort of omnipresent, or a lot of people have pain. And then when people have pain, providers and patients start looking for reasons to explain the pain. And when you get an imaging study of a shoulder, and I'm going to drop one number on you. I know we don't want to get too scientific here, but there's a study that just came out in JAMA, which is the most read journal in medicine, maybe second most read journal in medicine, that said that 99% of people over the age of 50 have a quote unquote abnormal finding in their rotator cuff on an MRI. So to me, saying that 99% of people have a messed up rotator cuff, that's like saying your gray hairs or your wrinkles in your skin are a problem that has to have surgery to fix. It's just not true.
Yeah, so
No, go
if
ahead.
99% of people have an abnormality, all of a sudden that abnormality is just normal.
Right, exactly. It's not actually abnormal. Your rotator cuff tear may not be a problem. It might just be like another gray hair.
Do you feel like there are some perverse incentives at play here too?
Yeah, I mean, that's just how the world works, right? There's a few bad eggs who do a few bad things, and then that reflects poorly on the group as a whole. So, yeah, there are definitely going to be doctors out there who treat MRI findings, and, you know, everybody's human, and some humans may care more or less than others, and they may be incentivized to do surgery. And so they feel inclined to do surgery for things that may be other than the best interest of the patient. But I really want to emphasize this idea of there's a few bad eggs in a group of tons and tons of people, and that sort of colors things in a negative way.
Well, there's also been this with back surgeries, for spinal fusions. When it comes down to the unnecessary spinal fusions, it's like, I forgot what the study was. Maybe 12% of physicians are doing essentially all of the excessive spinal fusions. So I'm not saying it's just shoulder surgeons. There's just definitely bad eggs in every field, right?
Yeah, I mean, if you ever listen to the Dr. Death podcast, the following seasons, not the actual original Dr. Death, they get into that exactly. Like docs mislabeling patients with having cancer and sending them to their own infusion centers to get chemotherapy. And anyone listening to this is going to start to think that they should just not trust doctors. But it happens in every field. It's like going to the mechanic because your tire pressure is low and you get a report that's got 37 things wrong with it, right? And then,
Yeah.
you really are sitting there asking yourself, are there really 37 things wrong? Like, is this guy trying to make money? You know what I mean? Like that happens everywhere. So you just got to understand what you're dealing with.
That's how I feel about pool guys and AC.
Yeah, exactly the same. Um,
So when was it that you realized that this was an issue? Because it feels to me like in a surgical residency, you're learning how to operate. At some point, you had to put the dots together and be like, we need to know when not to operate on these folks.
yeah, I mean, it really is sort of a lengthy process because the core problem with residency is you don't get longitudinal follow up with anybody, whether they were treated with surgery or no surgery. So you see points in time in residency, but you don't really see how those things tend to play out. Whereas when you come into practice, you start following people over a period of months or even years. And you also, especially if you're in an academic position like I am or a tertiary referral center, start seeing the consequences of other people's decisions. Right. And so you just start to see a whole host of folks that potentially are not doing so well after they had an intervention for an MRI finding. And they may have done very well or even better if they never had that intervention.
And so these people are getting a second opinion with you, or they're maybe coming to you asking for a repair of a previous repair.
Not necessarily a repair of a previous repair, but they're, and I tell folks as I market for this because it's part of what I do, but it's if you had surgery and you're not happy with how you're doing, you're welcome to come and see me with the strong caveat that I certainly may not be able to make you better and everything may have been done very well and appropriately. But sometimes folks, and my own patients have done the same with other surgeons. Sometimes if you're slow and particularly if you're slow to recover, you just need to hear from another surgeon and tell you everything's fine. It's going to be okay. You just got to give it time, which, you may not always believe your own surgeon when they say that. And so I see a little bit of that too.
Yeah. Do you have a time that you remember when you were doing your fellowship at Cleveland Clinic where you saw these patients come in and you thought, "Oh, this specific case is one that sticks with me of somebody that maybe shouldn't have been operated on or needed a perhaps a different treatment entirely?"
Yeah, not actually in fellowship at Cleveland Clinic, but in practice, I had someone come in early on who had an arthroscopic surgery and an augmentation procedure for their rotator cuff when they had a partial thickness rotator cuff repair, and they postoperatively subsequently developed a frozen shoulder, which is a stiff and painful condition that actually does resolve and does occur after indicated rotator cuff repairs, but it can take a long time to get better. And so that patient in particular had not had any conservative treatment of any kind. And they were very upset that they felt that they were sort of told they had to have a surgery, and then they did poorly with that. And that really does stick out in my mind as a relevant example of understanding when and when not to do surgery.
So when you're seeing patients with rotator cuff issues and you see an MRI, for example, what's your thought process going through that MRI as to when you can make a valuable impact surgically versus when, this is something that needs to be avoided?
That's a very good question. There are some very clear, obvious things that point you towards one way or the other. The most obvious of which is if somebody had an acute injury and that's when they started having an issue. That does better with surgery. So, hey, I was doing fine. I fell, or I was at the gym and I felt the pop. I was playing pickleball. There was a give in my shoulder. I dislocated my shoulder. Those folks, they probably didn't have their rotator cuff tear beforehand, or if they did, it was small and now it's big and should be sort of dealt with or treated. On the other end of the spectrum, you'll get an MRI that shows a rotator cuff tear with signs of chronicity. That means this tear is years old, but they've only had weeks of pain. That's not one that you want to be doing surgery on, because really what you want to do is get them back to where they were a few weeks ago before they had the pain, because that tear has been there for a long time. The middle group, and I tell patients this, very hard to figure out what's going on. Very hard to know if the tear is new. Very hard to know if the tear is the cause of your problem. But certainly you want to try conservative treatment options before you do anything aggressive, and in particular, understand patient goals. Pain is a challenging thing to treat, as you're well aware of. Loss of function, if in particular strength, if that's a complaint, is a different issue than pain, so to speak, and that can drive a conversation to surgery or no surgery.
Yeah, I always tell people they have 3 things that I can help them out with. If we get all 3 right, they're probably gonna be happy, and that's decreasing the pain, improving their function, and then decreasing their medication usage, especially now considering people just simply don't wanna be, taking medications. In your patients, I would imagine that you have to tell them after surgery, this is gonna take a little bit longer. But at the same time, if they are doing physical therapy even before a surgery that's in that gray area, I would expect they have better outcomes.
Yeah, I mean, this is clear across all orthopedic surgery. Preoperative range of motion and preoperative function are the strongest predictors of postoperative range of motion and postoperative function. So, absolutely, there's almost never not a role for therapy preoperatively.
Okay.
Um,
Yeah. Can you explain the different rotator cuff muscles and which are the ones that you feel like are the highest rates of injury and you feel like you have the most success in treating?
Yeah, so the rotator cuff, very simply put, is four muscles: one in the front, one on the top, two in the back. The one in the front is called the subscapularis. It's often found to be torn intraoperatively, but it's very difficult to sort of diagnose on preoperative imaging or even exam, just because of the anatomy and the way that imaging cuts are. You don't see it very well. And then more traditionally, the supraspinatus muscle, the one on top, which does the most work, so to speak, is also the most commonly torn. And that's the one where, in particularly with acute injuries or with sort of strength deficits, you can potentially help improve with surgery. There's also the infraspinatus muscle, which can be torn. That can cause sort of external rotation weakness. It's a very specific problem, very specific symptom, and one that you do want to talk about surgery potentially if that external rotation is really the problem. But again, that's not a pain problem. That's a very clear, distinct function problem. The fourth muscle, the teres, is rarely torn or rarely part of the picture. So I never really talk about it much. But
The supraspinatus seems like the one that's the most common issue.
it's even more than seems like. Empirically, it is definitely the most common issue. Um, this is a well sort of described thing from like 20 years ago, but a well-known shoulder surgeon named Steve Burkhardt described how the rotator cuff, in particular supraspinatus, worked kind of like a suspension bridge, and the force that is being applied to your shoulder as it's going through range of motion, particular elevation, hits the supraspinatus the hardest on the front and back parts of the tendon, the so-called crescent of the rotator cuff, and so that's where it tends to tear the most.
Okay. Surgically, what was the traditional approach and how has surgery evolved?
The traditional approach was take the rotator cuff tendon, which pulled off of the bone, which it's hard to understand for patients who've never sort of had it explained to, but it's like a rope that was anchored and the rope pulled off the anchor. You got to re-anchor it, right? Tear doesn't mean a sheet of paper that's torn in half. Rotator cuff tear means the anchor pulled off and you got to re-anchor it. So we use anchors and sutures and potentially other techniques to re-anchor the bone. The new threshold that we seem to be that's sort of exploding at the present time is quote unquote augmentation. So we can mechanically bring the anchor over and reattach it, but how do we improve the biological environment so that the repair takes? Because we know the bigger tears, especially in older patients, have a 10 to 40% failure rate, if not even higher, even when done in skilled hands and well indicated and the right patients and everything. So nowadays, it's all about understanding how can we augment our mechanical repair with some sort of biological or structural support that'll make it help or make a
It
difference.
sounds like encouraging proper healing. So, are you using things like PRP? Are you using other biologic substances or devices? What's the augmentation?
Yeah, I mean, this is a huge box of things, but yes, in short, yes. The reality is they're all available. Everything is an option. Everything can be done. Everybody does different things based on where they trained or what they believe in, um, and sort of what they think seems to work. The evidence is clear that augmentation helps in certain situations. Very unclear what kind of augmentation is better than other kinds of augmentation, so to speak. My personal philosophy: if you've ever spilled something and grabbed a bounty paper towel and you hold the bounty paper towel even close to the spill, it just starts sucking up fluid, right? And that's sort of an absorbent type property. So I believe in using augmentation that's a 3D scaffold similar to a bounty paper towel that you put on the bone and you put it underneath the rotator cuff because my personal opinion is that what that scaffold does is it holds all of the blood and healing factors in place. So it sits between your repaired tendon and bone and basically allows all of the biologic components to stay there so they can't go anywhere basically. And if you've ever worked in a lab, like cells grow on the appropriate media like crazy, right? You put bacteria in a little dish and they just spread across the dish. So
Yeah.
that's what I tend to use. But that's not structurally strong, but that's biologically strong, right? People who have bigger rotator cuff tears that may need to offload the force, that doesn't make sense. So then you may need to use some kind of collagen graft or something of that nature. PRP was shown to help in some studies, but recent data has shown that PRP injection by itself doesn't necessarily do anything, which to me makes sense. Like the shoulder is a fluid environment. So putting some kind of non-mechanical injection or component of cells in there, it's not going to stay in one spot. If anything, it would make more sense to take what I'm describing, the scaffold, dip it in whole blood or PRP, and then put it in, if that makes sense, to kind of hold it in
Yeah.
place. But that's definitely where we're headed.
It's all towards using your own body and scaffolding structures like that that will help the healing be a stimulated healing response rather than one that we're just mechanically anchoring something and hoping it takes.
Yeah, and I don't want to poo-poo that. It works. I mean, we've done it for a long, long time. But yes, we want to make it better. Like we've
Yeah.
reached the threshold of we understand this is the best mechanical construct. Now we got to improve other stuff. And the other thing I didn't touch on is nutrition. There's a huge amount of data coming out. A couple of guys and gals in particular leading the charge from a science standpoint, but looking at things like preoperative albumin levels, preoperative vitamin D, vitamin C levels, optimizing carbohydrate, protein intake postoperatively, and those things can make a huge difference in recovery.
So what was it about shoulder surgery that caught your interest?
Yeah, so I mean, it's a few things. One, I enjoy this sort of innovation space where there's still a lot to learn and a lot to grow. And in many areas of orthopedics, they're tapped out in terms of dramatic change. So, like total knees and total hips have been largely the same for 50 years. They're not going to change all that much. There are incremental changes, but they're not going to change all that much. Shoulder is the opposite. Reverse shoulder replacement is the fastest growing orthopedic surgery in the country. FDA approved in 2004. Today's implants are 100% different than the FDA approved implants 20 years ago. But 20 years is relatively young for a surgery, right? The vast majority of people doing your shoulder replacement surgery never did one in training, which is an important consideration, by the way. But they learned it on their own. They learned it in a lab, they learned it in courses. And that's a lot of medicine, but just to understand how new it is. That in conjunction with the fact that, on any given clinic day, I could see like a 17 or 18 or 19-year-old high school athlete who had a shoulder dislocation, and then the same day I could see an 87-year-old patient who fell and broke their humerus around a previous shoulder replacement. So there's just a huge spectrum of pathology and age and treatment that it doesn't, it's one joint, so to speak, but it's a lot of pathology. And I believe that, and this is going to be like the old heads are gonna be like, you're crazy. My dad, who's a hospitalist, tells me it's his lame, but I want my surgeon to be really, 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 really good at a couple of things. I don't want to go to the guy who does 27 things and says he can do them all very well because unless you're not a human, then you can't do everything exceptionally well. You can focus in on a few things and do those exceptionally well. I'd rather be the guy who does shoulder surgery exceptionally well. And elbow, I do some sports elbow surgery at a high volume too. But
Yeah.
outside of that, I'm not particularly interested in expanding the scope, so to speak.
Yeah, you're more interested in the innovation within the particular pathology, right, of the shoulder?
Yeah, and then again, just being really, really good at it. I mean, that you could argue that maybe it doesn't matter to be 3 degrees better, but I want the guy doing my surgery to be 3 degrees better. Like, you know what I mean? It's. I think we owe it to patients to be really, really good at what we do. And I think if you do 37 surgeries, you can be really, really good at 37 surgeries because again, you're a human. It's just the nature of being really good at something is you got to. It's adult learning is repetition and getting better is repetition. So.
Yeah. What is it about shoulder replacement that has been so successful and caused it to grow so fast in the last 20 years?
Um, For reverse shoulder replacement in particular, it does actually have what you could argue is a large margin of error, although it's not as large as people like to think, meaning that a lot of folks can do it and do reasonably well with it. And even though you could be a perfectionist and argue about my component should be here or this kind or whatever, and that could make it better, a lot of people get a good result, even if they have not perfect or not 100% precision, if that makes sense. So any
Would that be
surgery that's
similar
relative,
to a hip replacement?
yeah, very similar.
Okay.
So I actually tell patients that have had total knees and total hips when they ask about their shoulders, and they're like, "I'm never going through that again because my knee was very difficult to recover from." Much, much closer to a total hip than to a total knee, from a
Mhm.
recovery and that perspective. And the other thing is, you know, I think upper extremity pain is relatively just under-recognized or undertreated, and then a lot of people, it's this rotator cuff tear that people get surgery for, and they don't really get better or they don't have a great outcome, and it's because that was never really the appropriately indicated surgery. And it might have been that they needed a reverse shoulder replacement, and that's a great surgery that's appropriately indicated, has quick recovery, etc. So um,
So which
I think that's why
instances is the reverse total shoulder indicated in?
it's going to get a little bit technical here now, but really there's sort of two big buckets of shoulder pathology. There's rotator cuff tearing, that's pathological or eventually symptomatic, and then there's arthritis, where the ball and the socket of the shoulder wear out and the rotator cuff's fine. In the setting where you don't have a functioning rotator cuff and you're symptomatic, meaning painful, weak, can't lift your arm over your head, that does very well with the reverse shoulder replacement. That was the original reason that the reverse was invented. We didn't have a good surgery. We had no good treatment for irreparable rotator cuff. We said, sorry, it's going to hurt. It's going to suck. And now we have a surgery where people can do very well with it. And then if you have enough bone loss from primary arthritis or wear and tear that you can't get good fixation of an anatomic shoulder replacement, then you can do a reverse shoulder replacement. And those patients do very well.
Okay, and a reverse shoulder replacement is when you take what is the golf ball that's sitting on the tee, the head of the humerus on the glenoid, and you reverse them, correct?
Yeah, I have no idea who thought this would be a good idea or why they thought it would be a good idea, but they did, and it's worked out very well. So yeah, you put the ball where the socket used to be, and you put a plastic socket where the ball used to be, and you
Yeah.
don't rotate cuff anymore, and it works very well.
Wow, that's incredible.
That's innovation.
Do you that is. I mean, I see why you like the space. So,
Yeah, it's cool.
um, you mentioned earlier that second opinions are something that you encourage, and you even invite people to come see you for a second opinion with no promises.
Sure.
What is it about that population or that seeing people for second opinions that you enjoy so much?
I think that this is going to sound really lame, and a lot of people become jaded, and maybe at some point they never did it just because they wanted to help people. But I still like to cling to this idea that the reason we do this is to make people better and to help people that don't have another avenue to help themselves. And the people that I feel like, or I'm going to digress for a second. Do you know who Joe Ionati is?
I don't.
He was chief of orthopedics at Cleveland Clinic. He was the chief medical officer at Cleveland Clinic, Florida. And now he's back to just being sort of professor emeritus at Cleveland Clinic in Cleveland. He tells this wild story about how the best, most satisfied patient he ever took care of started off with a really, really, really terrible shoulder and ended up with a marginally better, still terrible shoulder. But for that patient, the improvement from, hey, my shoulder is 15% and now my shoulder is 35% was a 20% improvement. And they were thrilled because they couldn't use their arm for any reason, but their pain went away and they were very happy with that. And so I find that sometimes the most rewarding patients are the ones who have a really terrible situation and that you can improve it, even if you can't improve it to the extent that you might have been able to do with a first time surgery. Um, I had a patient in the office recently who came in and told me their subjective shoulder score was 80% out of 100. And they were booked for surgery with another surgeon. And they wanted another opinion. And I was like, listen, best case scenario, your shoulder gets to 95 to 98% out of 100, maybe 100%, right? Are you really unwilling to go massive surgery and a joint replacement and a surgery for maybe a 15 percentage point improvement? I don't think it's worth
Yeah.
it. It's up to you to decide, which is what I tell patients, but I don't think that's worth it. So to your point, these revision folks are often at a 20 or a 30% of their, where they were, or for like periprosthetic fractures or infections, they're at 0 or 5% of a normal shoulder. So those are huge wins and very satisfying, patient experiences where you can get them substantially better from where they're at.
Yeah. So when it comes to the people that have an MRI of their shoulder for shoulder pain and they see what appears to be a chronic appearing rotator cuff tear, would you say lean towards PT, lean towards doing conservative care on their own first if something traumatic didn't happen, rather than going to see a shoulder surgeon right away? Or would you tell them, hey, go see a shoulder surgeon, but if you get offered surgery, strongly consider a second opinion or just doing the conservative treatment for a while first?
So, although my title is shoulder surgeon and I love to do surgery, I tell every primary care doctor or every patient or every PT that if a patient has a shoulder, I'm happy to see them, and most patients have too. So, I don't care if they've had conservative treatment or not. I'm still going to recommend that if I think it's the right thing to do. So, I strongly agree with the second thing that you said. If you have a new onset or some sort of chronic shoulder problem that you is bothering you enough that your daily life activities or the things that make you happy and satisfied, like playing golf or playing with your grandkids, are compromised by it, come and see one of us. And yes, if the first opinion offered to you ever is surgery, you should lose absolutely no sleep over going to get a second opinion.
Yeah. And, that's the title of the show, Second Opinions. So, Dr. Patel, thank you so much for coming on. I appreciate you. If you're a patient, go get a second opinion if you have a chronic rotator cuff tear, and hopefully you go see Dr. Patel at Banner.
I would love it. Happy to see folks. Thank you.
Awesome. I'll see y'all next week.